Now this is a really interesting one. Just ignore all the figures on the bottom, they don't matter at all just now. But just to explain it a little bit, this is 24 hours along the bottom, so that's 1 o'clock, 2 o'clock, 3 o'clock throughout the 24 hours of the day. Each of these coloured lines represents a different day of the week. And once again, the number of accesses are up on the left-hand side here. So you can see that from midnight, there's a small but constant number of accesses to ECS every day of the week. But Saturday and Sunday, as soon as people start to wake up and call NHS 24, up it goes. And then the calls gradually come down. But for all of the other 5 days of the week, there's still a steady background number of accesses, probably from A&E and other users. And then at 6 o'clock, as soon as the GP surgeries are closed, up it goes. Huge number of calls over the evening and then back down again. And this is just a typical week, but it shows that the emergency care summary information is being used. People are using it. I know that doesn't prove that it's a great thing, but it does prove that people are still using it. We've got lots and lots of information for anyone who's thinking of implementing summary care record in England. If they would like to see any of our stats, we'd be very happy to share them. They're all on our website. There's lots and lots of interesting variations. This was one particular one from the border, again split into different users, but you can see what happened when they had a problem with their out-of-hours system in June. And so it's not just all the people thing, there's a technical aspect to it as well. And then once again, peaks in December, Christmas, January, peaks at Easter when there are public holidays. Now this is another interesting one. This is Dumfries and Galloway, and the thing I'd like you to look at here is the turquoise line at the bottom. This is the A&E accesses. You can see it was running along at very, very, very small numbers. And then on the 1st of August last year, they gave all the new medical staff passwords and training. And then suddenly, with passwords and training, up it went. And then once they discovered it was there and it was useful, the numbers and accesses just took off. Now, we've done a pharmacy evaluation in 3 acute receiving units. Every single pharmacist who replied said that they found it either useful or extremely useful. They're using it for medicines reconciliation. They are picking up all sorts of things that the patient forgot to tell them. They are finding it saves huge amounts of time. They don't need to phone the GP practice. There was overwhelming feeling that they would not want to do without it now. These are just some of their quotes. We've got some eye-watering clinical vignettes, if anyone's interested. We've got a whole lot of actual stories on the website. Some of them I'm not sure about publicising too much if patients really knew what went on. But as I say, the pharmacists would not want to be without it now. We're about to pilot it in an outpatient department and also for medicines reconciliation in non-acute units. A&E evaluation. We asked over 200 clinicians what they thought of it, and again to rate it on a scale of unhelpful to very helpful, and over 70% of the clinicians found it either helpful or very helpful. And even more interesting, over 30% of them said that it had changed clinical management. So in other words, their decision of what they would have done for the patient had actually been changed when they looked up ECS. Either they'd seen something that they hadn't known about, or for example, there was one patient who had gone in with angina, who was about to be prescribed a nitrate. They looked at his ECS, realised he was already on maximum dose of nitrate, so rather than overloading him and overdosing him with something, they changed and gave him something different. The first one, I think, is probably quite obvious. An awful lot of people who are on multiple medications have no idea what they're taking, and if they're ill or unconscious or they've had a stroke and they can't speak, then obviously there's big problems with communication. So having a medication record does save time. But much more worrying, in the evaluation, one of the pharmacists found out that at least 50% of details that they had before ECS was wrong. Now that could be a dose, it could be an adverse reaction, it could be a medication, but over 50% of people's records had something that was wrong, and that's quite startling. Now this EU evaluation was actually carried out by an independent team from Germany, who were looking at several different shared record projects, and Scotland was just one of them. And they produced this interesting graph. Now, on the left, rather than accesses, this time you can see pound signs. Now, the pound signs for the yellow bars are obviously actual pound signs, because that's how much the implementation cost, whereas the blue bars, which are the benefits, are sort of proxies really for pounds. In other words, how much is a life saved, how much is the prevention of an accident, how much is a medicine's reconciliation worth. So what they found is that in year one, over there 2002, the costs were very, very, very small. Now this is because we spent a year just discussing it. We took a year to decide what it would be, we took a year to agree on how we would do it and what would happen. Then 2003 we started with the first pilots, 2004, and then 2006 was the main rollout. And then after that, the costs are coming down to a steady state, whereas the benefits obviously take a few years to ramp up, but they're increasing all the time now. So what lessons have we learned? Well, certainly the incremental approach works for Scotland, and we're using that model to roll out all of the extensions to the basic framework. Careful consideration of patient groups and clinical needs. I think what we're finding is that ongoing patient and clinician communications is challenging in both directions. Obviously, we need to get feedback. What we discovered was that some pharmacists in hospital felt that some of the ECS was inaccurate. Now, it's not really inaccurate, it's just that it only contains medication from primary care. It doesn't contain any prescribing from drug clinics or CPNs or elsewhere. So it's not inaccurate, but it's certainly incomplete, and there is a warning screen right at the beginning to warn clinicians about it. That's part of the training as well. Interestingly, somebody this morning mentioned about junior doctors not being familiar with electronic health records, but actually what we're finding in hospital is because they come from a digital age, they think if it's on the computer, then it is fact, and it's like reading things in the newspaper. If you get an ECS that's printed off, instead of thinking, I wonder if there's anything else, or we better just check this with the patient, they tend to take it as fact. So it's an ongoing story. But clinical leadership and clinical championship, if you've got someone who says, look, this is really, really good, I recommend you all do it, then you're halfway there. So in summary, we've made fantastic progress. It's just business as usual. It's rolled out for virtually every patient and in virtually every practice in Scotland. The security comes from the integration of the systems. That's as technical as I'm going to get. I can answer lots of questions later if anyone would like me to, and there's loads and loads of technical information on the web, but basically that's as much as I'm going to say just now. The evaluations show overwhelming support, and we've got good evidence of benefits. So we've got lots of plans for the next stage. We're currently rolling out a palliative care summary, which adds on to it, and we're going to have another shared summary which will be for patients with long-term conditions and mental health problems, and that'll all hang off the same technology. So I'd be very happy to answer any questions, and as I say, give you the website. We've got lots of information. Happy to share it.